Good afternoon and welcome to this Top TUT tutorial with the CMH Family Medicine Department. We are now going to be focusing on deep vein thrombosis as well as pulmonary embolism. And this is the first one in our series of a few targeted tutorials on how best to diagnose, recognize, and manage thromboembolic disease. And this very short tutorial is first just going to focus on understanding who is at risk. So quite often when people come in with either a DVT or a pulmonary embolism, they might just present with only a swollen cough, or in the case of pulmonary embolism, perhaps even just with a cough. And what's very important is to understand with which of these patients do we want to have a high level of suspicion that there might be some thromboembolic disease going on. Just quickly running through our basic definitions. So when we talk about a thrombus, we're actually talking about a blood clot that is busy forming within a blood vessel. And when that thrombus closes that blood vessel up and completely occludes it, then we actually call that a thrombosis, and that's when the trouble starts. Now, the next thing that can happen is a piece of that thrombus can actually break off and be let loose inside the vascular system, and that we will call an embolus. And when that embolus gets stuck somewhere, for example, as it does in the lung, and ends up blocking off the vascular supply in a particular area, then we call that an embolism. So that's just a little bit of definitions. And of course, our concern is when somebody has formed either a deep vein thrombosis or a pulmonary embolism. So who's at risk? And I think all of you know the little virtual triangle of different things that might combine to create an increased risk of thrombosis in a particular individual. But there's quite a nice sort of mnemonic. They've managed to make it spell thrombosis to make us look at all the kinds of patients that might make us want to consider that somebody might be at risk of a thrombus or a thrombosis or an embolism. So very important is just to always get some travel history. So especially if somebody's been on a long haul flight, in our South African setting, quite often people might have been on a taxi or a bus overnight, and very important to get some history of whether they've actually had a thrombus in the past. Your H stands for hospitalization. So all patients that are hospitalized, especially if they're quite immobile, we need to consider their potentially increased risk. And we want to ask, the R stands for relatives. We want to know if there are any family history of clotting problems in other members of the family. Our older population are definitely more vulnerable. It might also be familial or because they're less mobile. So if they're over 60 years, that in itself counts as a risk factor. And then the M stands for malignancy. So malignancy in itself, as well as the treatments we use for malignancy, increases somebody's risk. But there's also various medications, and thalidomide we don't use that much, but very commonly is patients who are on some form of estrogen. So whether it's contraception or hormone replacement therapy, that increases your risk as well. The B talks about actual blood disorders, for example, having a blood disorder like a thrombophilia. But bone fractures is the other B. So especially long bone fractures of your bone, of the femur, for example, fractures of the leg, and especially because there's prolonged immobilization is going to increase that risk. Our O stands for obesity. So obesity in itself is a risk factor, and obstetrics very important. We'll have a whole separate tutorial just focusing on pregnant and postpartum women. The S stands for surgery. So this is people who have had recent surgery, and we'll look at the exact risk factors under the prevention section. But smoking in itself also increases causes hypercoagulability and makes it more easier for you to form clots. I is for immobilization, so any reason why you might be stuck in bed or not be able to move around very much. And then there's a whole list of actual illnesses or sicknesses that can cause chronic heart failure with congestion, especially if you've got quite bad edema of the legs or nephrotic syndrome with edema. But just look, HIV infection in itself, especially our end-stage HIV infections, also increases your risk, as well as a whole host of autoimmune diseases. And then patients with TB, just having TB in itself can increase your risk for DVT. So this is a fairly sort of a mixture of all kinds of different types of scenarios that we need to keep in mind. And when you have a patient with any of these risk factors that are presenting either with a swollen cough or with sort of lung symptoms, coughing, or particularly shortness of breath, we want to start thinking about, could this be a thrombosis or an embolism? So our next little tutorial is going to focus specifically on how we diagnose and some clever scales that can help us make these decisions a bit easier.